It is my great pleasure to introduce a brand new faculty member that started in December with us here at the University of Louisville in the Department of Gastroenterology, Hepatology, and Nutrition. I'm going to tell you a little bit about Loretta. Dr. Jophlin actually received her BS from Charleston, South Carolina, and graduated magna cum laude. She then stayed there and got both her MD and her PhD, and I was interested, your thesis is on crosstalk between retinoid and TGF-beta signaling, so that will appeal to the scientists in the audience. Loretta then went to Mount Sinai for internal medicine and received an award for Intern of the Year, completed her residency there in 2014, and then went on and to get her GI fellowship in there as well. She then got a transplant hepatology fellowship in Mayo Clinic and was an assistant professor both at Nebraska and then also in Mayo Clinic. Kind of along that way while she was publishing more than 20 peer-reviewed articles, more than 30 abstracts and posters, Matt Cave and Craig McLean met her, I think, at a meeting and decided that she was definitely the real deal. She's clinical and she's scientific. She's had continuous work on NIH grants since 2005, and big round of applause. She just got a KO8 award, which is a career development award, and it looks like you're going to be continuing to study microtubular cytoskeleton and its interactions with fatty liver. She is serving us now as the medical director of liver transplant, along with Louis Marsano. And I asked her what she's most proud of, and I loved her answer this morning. She said, true grit, perseverance. Don't get disappointed if your first grant isn't accepted or if publications get rejected. So with that, I welcome Loretta, and we would love to hear about liver transplant, past, present, and future.
All right. Well, thank you so much, Dr. Kruger. It is a great honor to give grand rounds. I think this might be the last grand rounds for a bit. And I want to share with you some of my knowledge and also get some feedback regarding liver transplantation, where we've been, where we are right now, and where we're going. So we have right here Thomas Starzl, who I have to admit I'm a fan. He is the father of liver transplantation, and he showed grit and bravery. And if he hadn't done what he did in 1963, I don't know where we would be, and I don't know how many lives wouldn't have been saved. And then here we have a depiction of our current organ allocation scheme that is always a work in progress, so that we can justly and equitably allocate this most precious national resource to individuals who need it most. That is probably the greatest gift that one person can give to another, and that is organ donation. So a summary of what I'll be giving today during this grand rounds is a history of liver transplantation, case presentation, the aims, indications in the evaluation process, donor and recipient operations, complications of liver transplant, care of post-transplant patients, new developments on the transplant scene, and I hope to convey to you the importance of being an organ donor and donating life. There are certain areas that when I was reflecting on this talk that I have completely ignored. I have completely ignored a lot about immunosuppression and certain surgical post-transplant complications, as well as various nuances of the evaluation process. But I'm always here to answer questions, and I know our entire transplant team is open to receive questions about the evaluation process for any patient that you may have questions about. So the history of liver transplant, this is a relatively new field that was born on the shoulders of kidney transplant. So the first attempt at kidney transplant in 1902 really wasn't followed by a successful kidney transplant until over 30 years later, and actually over 50 years later. The first liver transplant was in 1963, and it was at the University of Colorado, of all places, and Thomas Starzl did that transplant, and it was not successful. And it really wasn't successful for many years later until we had adequate immunosuppression. And I would say with cyclosporin and tacrolimus, these tools have allowed for us to circumvent the rejection of organs. The liver is a little bit more forgiving. Kidney rejection has also come a long way with some of our new biologics, as well as other immunosuppression agents that have been developed. And that's an active area of research. Living donor for liver transplantation is also relatively new. In the late 90s, we had our first successes, and then the MELD was implemented as a means to more fairly allocate organs to individuals based on how sick they are. And that is still a work in progress. Attempts to allocate organs in a way that represents all areas, rural and urban, as well as Puerto Rico, Hawaii, and Alaska. Getting organs to those individuals still remains a big challenge. So the first liver transplant at Jewish at UofL was in 1990. Since then, the average of transplantation number has been about 18 liver or liver kidney transplants. And I may be off by one or two here, but as of 4/8/2021, we have about 982 liver transplants. So we are approaching the 1,000 mark, and I propose that we have some kind of a celebration akin to crossing the equator on a boat. And I know that the individuals who've been transplanted here are also very excited about that. So thinking about how we get a liver from one individual to another individual, I'd like to present two cases in parallel. One is of tragedy and one is of hope. So 7:59 a.m. Friday, March 26th, Mrs. D, who is Mrs. Donor, is in a car accident on her way to work. She's briefly conscious when EMS arrive, but she has a seizure on the way to the hospital. She's intubated in the emergency department, and a stat CT of the head shows a posterior hemorrhagic stroke. She spends 12 days in the neuro ICU, and an EEG confirms brain death. She is an organ donor. Her family knows this, and it's indicated on her driver's license. 8:15 a.m. Wednesday, April 7th, Mr. R, which is a recipient, checks into liver transplant clinic for a waitlist update. He's been on the transplant list for 7 months with a MELD sodium of 23. He gets large volume paracentesis every 2 weeks, and there's a lot of suffering in this in his daily burden that he has to carry. He arrives in a wheelchair pushed by his wife. He's been lethargic because he spent 6 hours yesterday doing something that normally took him 2 hours, which is cutting the grass. And today, his MELD sodium is 31, driven by acute kidney injury and hyponatremia. So we think about the 3 phases of organ recovery, how Miss D becomes a donor, and how Mr. R gets the organ. Phase 1 is procurement. We no longer call this harvest, probably for obvious reasons, but coordinating with donor hospitals to procure organs from deceased donor patients who meet clinical criteria for donation. That's the goal here. Discussion between organ procurement organizations, which are also known as OPOs, in the family and the hospital. Phase 2 is the match and recovery, matching the procured organ with a patient on the waiting list to receive that organ and overseeing the surgical recovery of the organs. This is orchestrated by UNOS, and there is a website, DonorNet waitlist, deals with donors and putative recipients. The honor walk is when an organ is procured from a patient in the hospital. I've been getting pages for these. I have attended them in the past, and it is something that I encourage you all to try to attend. because it is sobering and it's inspiring. And it really does underscore the generosity of families and donors in giving somebody a gift that will give them a new shot at life. Organ recovery teams mobilized. They've actually already been mobilized. The recipient is called in for a possible transplant. This is the UNOS user ID password where transplant professionals log in to see waitlist and donor net. I would have logged in for you, but this system is strictly audited, and so I don't want any hits that are unnecessary. So in looking at donor organs, particularly livers, about 90% are cadaveric and 10% are live donors. We do not do live donor living transplants here yet, but that's something that is a possibility in the future. Certain transplant centers do it. They do high volumes. I would say that it is something that if you have a patient with a low MELD, a live donor may be a better option for them to actually get a transplant. And really the only thing I'll say about this is there's a 0.3 to 0.5% chance of donor death. And so live donors have to be in pristine condition. They have to have enough liver to give part of it. And when a donor death happens, it can happen to high-profile, excellent centers. There was one when I was at Mayo Clinic, and that's just a devastating event. Cadaveric donors, 70% are brainstem death, and the death is confirmed by neurological criteria. And there's a lot of debate in this area right now. That some ethical controversies are involved, but the bottom line is Mrs. D did demonstrate brain death and wanted to be an organ donor, and so we are really truly honoring her wishes with brainstem death donation. Circulatory arrest is DCD, that's donor after cardiac death. That's 20% of the organs that are used, and these are data from the UK. It's very similar here. And there are two types of DCDs. One is controlled, where an individual is typically on life support and further care is thought to be futile. There is no chance of recovery, and so there is withdrawal of the life support, and death occurs. And there may be a period of time where the organs are poorly perfused. And so that is our warm ischemia time, and this is the reason why DCD donors may not be as pristine organs as brainstem death donors. Uncontrolled DCD death is a lot more rare. This is somebody who comes in cardiac arrest and cannot be resuscitated and doesn't have circulation, and so it's just a very rare situation where organs are viable to be retrieved. So phase 3 is transport and transplant. This is transporting the recovered organ to the transplant center in sufficient time so it can be transplanted successfully. And I just want to give a nod to the procurement teams here. This is an extremely risky job. This is our transplant surgeons who, we see every day in clinic, their colleagues and coordinators who go out in the middle of the night in bad weather, in very small wing planes in urgent situations. And there's a paper in AJT in 2009. I really hope that this is no longer the case, but the risk of fatality is 1,000 times higher than a scheduled commercial flight. And here are two news articles, one more recent, Mayo Clinic in Florida, and then this terrible tragedy that happened in Michigan when the entire transplant team died in a crash. So back to Mr. R. When he was seen in hepatology clinic that 7 months prior, he had no idea he had liver disease, and this is often the case. So he was referred to HCOC for chief complaint of echogenic liver and trace ascites that were incidentally found on an ultrasound done for a kidney stone that later passed. His vital signs were showing features of metabolic syndrome. Platelet count was low, which is Always a telltale sign that maybe portal hypertension is developing and the spleen is sequestering platelets, driving the platelet count down. LFTs were a little bit abnormal. Sometimes people don't bat an eye at LFTs that look like this, but they can actually be a signal that there is some inflammation in the liver. And by the time people are cirrhotic, sometimes the LFTs normalize because the hepatocytes just don't have any more inflammation to give. Bilirubin's a little bit up. There is coagulopathy. Creatinine is up, and then the sodium is low. Hemoglobin A1C 9.2. FibroScan done in clinic showed liver stiffness of 18 kilopascals, and that falls within our cirrhotic range, and a CAP, which indicates a severe level of steatosis or fat in the liver. I wish I had time to go into FibroScan, but maybe that'll be a different talk. Physical exam showed middle-aged male, mild sarcopenia, which is a peripheral muscle wasting that can happen in cirrhosis, and when it becomes profound, can actually become a contraindication to transplant. He also had central adiposity. Exam was otherwise unremarkable. And that picture down there of that gentleman is Patrick Kamath. He is created the MELD score. He's one of my mentors at the Mayo Clinic, and he's just about the nicest person you'll ever meet. When you're in clinic with him and there's a patient who is very sick or learning that they have cirrhosis, he will ask you, what does this patient need? And you calculate the MELD score. And sodium, because it has been found to reflect the illness of the patient, has been integrated into the MELD score since he developed the first MELD, and our patient's MELD was 22. So besides calculating the MELD score, often patients who learn they have a new diagnosis of cirrhosis, which is also known as the other C word, it's just as devastating as cancer, the correct answer for Dr. Kamath is that the patient needs a hug at that point. So new diagnosis of cirrhosis is often followed with the phrase, but doc, I don't drink. There are many causes of cirrhosis, and generally in that first clinic visit, we can figure out what has caused it, but sometimes it is a mystery, and we will need to proceed with going down the route of liver biopsy, but often we don't need to do that anymore. So in the case of our individual, Mr. R, he has NAFLD, non-alcohol fatty liver disease, and we have to rule out all of these others because if he is a transplant candidate down the line, some of these diseases can recur and you need to treat them differently. So that first clinic visit where a patient finds that they're cirrhotic or they have cirrhosis, it's hard because you realize you have maybe 15 or 20 minutes to go through this with them. And so I've created some educational material, and I know that every hepatologist has their own style with this. But I like to break down cirrhosis in stages. I know that this is not a traditional way of thinking of cirrhosis, but patients ask, what is my stage of cirrhosis? And so I hope to convey that to them with this chart. So I classify as pre-cirrhotic, compensated, decompensated, and also decompensated, but stage 0 through 4, the risk of dying in a year. And patients actually receive this information very well. They want to know what they're up against, even if this 60% is very scary. External signs, I will drive the point home that this can be silent, and it's not necessary that to talk about that maybe this was missed by another provider. Why didn't we know this? Well, this is just how it presents. There's no fault here because cirrhosis is silent, and we don't have a good means of screening for it at this point in time. So, our gentleman, Mr. R, is probably right about here from the way that he presented, stage 2. Treatment plan, I like for patients to know and have this take it home and think about the things that they can do to be proactive about their health and in light of this diagnosis. I tell them what to avoid. If you're diagnosed with pre-cirrhosis or cirrhosis, it has to be a hard line that you're not going to drink anymore. Adding that additional metabolic stress to the liver is just not a good idea. There might be underlying pathways of addiction that you're dealing with, or someone may not be a problem drinker, but I would say let's just give a hard line and say no alcohol, and that's what I do. Debunking the myth that Tylenol cannot be taken is something that I have to do, and I let my patients know most of the time 2,000 milligrams daily is safe. Avoiding NSAIDs is critical. Explaining to patients how a high salt diet does not benefit them in the setting of having low serum sodium is something that I'm still trying to figure out. If anybody has any tips on that, please let me know. The testing that individuals can anticipate, ongoing upper endoscopies, scanning for surveillance for HCC every 6 months, and then considering liver transplant in select cases. I let people know that that's on the table very early on, even stage 1 and stage 2 cirrhosis. So when to refer for liver transplant? A diagnosis of cirrhosis does not necessarily imply that someone needs a transplant. Many patients with cirrhosis can be well compensated for years, and that longitudinal follow-up every 6 months with your hepatologist or primary care provider if a hepatologist is not available, I think that's key for their best outcomes long-term in your compensated individuals. Liver transplant should be considered once a major complication occurs, and that's ascites, a variceal bleed, encephalopathy, hepatocellular carcinoma that cannot be resected, and worsening function of the liver with jaundice, coagulopathy. A MELD score of 13 is usually traveling along with these kind of decompensating events. So survival is different between patients that are compensated and decompensated. Compensated cirrhosis can have a median survival of greater than 12 years. And these are data from 2006, and so this might even be better. Decompensated cirrhosis, the ascites, varices, encephalopathy, and cancer, all combined, the median survival is around 2 years, though some of these actually do travel with worse survival. So the survival benefit of liver transplantation, this was actually determined relatively early on, and we know that a MELD score of less than 15, usually less than 13, actually conveys more harm or risk to the patient in the setting of transplant most of the time. So, and another way of saying that is that doing a liver transplant has a higher risk of death to the patient or complications than the patient is already suffering. So someone with a MELD score of 12 or 13 might have anywhere from a 1 to 5% chance of dying in a year. And with a liver transplant, that first year, they have a risk of around 10% of dying from complications of the transplant. So primary reasons for a liver transplant, I think we've already talked about this a bit, but cirrhosis, decompensated or with cancer, acute fulminant liver failure. This can be from toxic ingestions of Tylenol, drug-induced liver injury. Sometimes we never figure out why somebody comes in with fulminant liver failure, and I'd like to start putting our acute alcohol hepatitis folks in this fulminant liver failure group, though that's just how they present. Other indications are hilar cholangiocarcinomas. We don't transplant a lot of folks here with that, but we could in the future. There are some centers that do high volumes of that because it's kind of a tricky disease. Amyloidosis, primary hyperoxaluria, polycystic liver disease, which is basically the liver is functioning, it just becomes quite huge with cyst, and if you can't unroof or debulk those, then a liver transplant, you can get a MELD exception for that. And neuroendocrine tumor, we all remember Steve Jobs got a liver transplant for this indication. So in looking at our SRTR, which is, this is a data collection for all of our transplants in the United States from 2008 to 2018, we have had a shift in the indications for transplant. Notably, hepatitis C virus, we have a decline. It's actually about half because we have such remarkable treatments for hepatitis C now, and we have a really great hepatitis C clinic here. Alcoholic liver disease, let's just call it alcohol-associated liver disease. We have an increase, and this is actually rising, so about 30%. Down here, medical urgency, you'll see we are transplanting people that are sicker with higher MELDs. So back in 2008, over 50% of people had a MELD score of less than 15, and now we are at 43. A MELD score of greater than 35 was a small fraction, and this is actually growing. So people have to get sicker to get organ offers. Back when I was in fellowship and residency, people would walk into the hospital with a MELD of 18 to 20 with an offer. Now it's very rare to see somebody that's literally not in the hospital already with a high MELD score get transplanted. So down here, just one nod to this is that MELD does not reflect all suffering. There is an entity called the National Liver Review Board that is made up by hepatologists, surgeons, ad hoc members from the community who review patient cases on a case-by-case basis and assign MELD exception points. This is a work in progress. Right now we're going with something called median Melded transplant. So all of the transplants, the MELD scores where the patient was transplanted at a center, the average, and then you subtract 3 from that, and you list your patient who has one of these conditions that you can get an exception for. I'd love to go into this more, but I feel like right now that information is quite in flux, and so presenting something that might be different in 6 months, honestly. So aims of liver transplant. Folks want to know how long this new liver is going to function for them. And so 86% of people, probably more than that, are alive 1 year after surgery. 78% 3 years, 5 years 72%, and 53% at 20 years. So in general, if somebody wants a hard answer, it's okay, average liver lasts 10 years. But there are so many people here that have been transplanted at Jewish that long-term outcomes, just doing so excellent decades out, and that's just a testament to how awesome our coordinators are. Many have been here since the inception of the program or right around that time, and you know, our surgeons do such great work. And so we are very lucky to have the team and the program that we have, and our patients here doing so well. Liver transplant improves the quality of life, but it doesn't fix everything, and it can cause new types of sufferings. So it's very important to set pre-transplant expectations. Individuals who say, if only I could get a liver transplant, then life would be perfect and good again. I just want people to know you're probably not going to feel as good as you did you know, when you were in the prime of your life. Liver transplant is to give you back quality of life, but it's a new way of life. It's taking medications every day faithfully. It's lots and lots of doctor's appointments. It could be prolonged hospital stays in that first several months after transplant, and then also just making sure that people understand that there is that 10% chance in that first year that your outcome may not be what you want. So expectation setting is key. So alternatives to liver transplant, tips: transjugular intrahepatic portosystemic shunt. This is a conduit that is placed between the inflow and the outflow of the liver to decompress portal hypertension. It fixes the plumbing problem, ascites, varices, and sometimes hepatorenal syndrome, but it does worsen portosystemic encephalopathy, and it doesn't fix the substrate for cancer. And so basically this conduit allows for blood that has not been filtered by the portal vein coming from the intestines with all kinds of metabolic toxins and byproducts to go straight into your systemic circulation and cross your blood-brain barrier. Other alternatives to liver transplant, continuing compassionate care for debilitating symptoms. This would be setting up large volume paracentesis that are standing for your patients I think the patients that are in rural communities, this is a lot of suffering. There's limited resources for doing these paracentesis, and one of my dreams in life is to have an at-home paracentesis service for folks that are dealing with ascites. There's other innovations. Dr. Kamath was a pioneer on something called the alpha pump, which takes your ascites and reroutes them into your bladder so that you urinate out the ascites. But the device has been riddled with complications. But I think it's such an excellent idea, and maybe something like that down the line will be widely available for folks. Aggressive portosystemic encephalopathy care. Patients globally hate lactulose for good reason if you've ever tried it yourself. But adding rifaximin, zinc, probiotics, branched-chain amino acids, and then also if you have a portosystemic shunt that is allowing for those metabolic toxins to enter to cross your blood-brain barrier, you can target that dominant shunt. But think about it as a reverse of TIPS. So there's decompressive shunts for your portal hypertension, and this would be blocking one of those. You can make ascites worse, but IR can be very helpful in placing amplitazar plugs or other plugs in those shunts. Knowing when to liberalize care for people who have cirrhosis. If somebody truly only has maybe 6 months to live and you have them on a low salt diet and they're suffering with that and they just want to have something that they used to like to eat, just kind of think about the quality of life and let them have that. And then a low threshold for referral to palliative medicine. I'd like to get those providers involved early, and most patients are amenable to that because they do have profound suffering. Contraindications to liver transplant. If you want to get me riled up, this is where we can talk. Lack of insurance coverage. The bottom line is if you don't have insurance in this country, you're not going to get a liver transplant. So that is probably, it's just a profound disparity. Active alcohol or drug use. I put an asterisk next to this because this is no longer a hard rule. We see alcohol use disorder as it's a disease, much like diabetes, obesity, for which we transplant other individuals with NASH or NAFLD. And so if somebody has not been given the resources to have their alcohol use disorder treated, then we as a transplant community are opening doors, trying to facilitate that level of care and trying to save people's lives in the midst of acute alcohol hepatitis. So we are starting to transplant individuals who present in this way. It's extremely select and takes a lot of coordination with mental health providers and partnerships with intensive outpatient treatment programs throughout the community. Hepatocellular carcinoma with extrahepatic disease. We just can't transplant folks who have metastatic cancer. Other non-hepatic malignancies with an expected survival of less than 3 to 5 years. Severe cardiopulmonary disease, other comorbidities, coexisting severe psychiatric or behavioral issues that are likely to interfere with post-transplant care. So if somebody does not like to take medications and they have shown that they just don't like taking pills, I would talk to them and see, okay, if you could take just the limited amount of immunosuppression faithfully, then maybe we can get past a barrier like this without labeling somebody as being non-compliant. And then a lack of social support. This is also something that my perception of a lack of social support is going to be very different than somebody else's perception of that. For instance, I had a patient who presented with fulminant autoimmune liver disease, and she had no parents, no siblings, no spouse, and she also had social anxiety disorder, so she had very few friends. And so her lack of social support, not having a dedicated care partner, at first glance makes her not a transplant candidate, but she's put out a message on Facebook to all of her people that she knows, and was overwhelmed by the number of people that were willing to give 3 months of their life to partnering with her. And she's now about 1.5 years out from transplant and doing great. So as I alluded to, active recent alcohol use is no longer a strict contraindication to transplant. New England Journal of Medicine 2011 Pinnacle paper that came out of France showed that individuals transplanted for acute alcohol hepatitis who would have otherwise died have outcomes that are just as good as individuals who are transplanted for other causes of liver failure, liver disease, and they have similar rates of return to alcohol use after transplant as those people who have 6 months of sobriety. The Dallas meeting, I was there. It was great. We came up with a consensus statement on transplantation for liver transplantation for acute alcohol hepatitis. So if you want to refer to these or reach out to our team about that, if you have patients that are actively drinking and you're not sure if they'd be candidates or not, go ahead and just refer them our way and we can sort through that. So the evaluation, lots of labs. Cardiovascular and pulmonary evaluation, this is based on each individual. If someone has a long history of smoking, they'll need PFTs. If somebody has an abnormal echo, they may need a cardiac cath. The evaluation process is pretty intense. It occurs over a couple of days. Imaging that's needed, pretty standard and screening test. Individuals have to be up to date on their routine healthcare maintenance. The consultation begins with the nurse coordinator, which is the heart and soul of every transplant program. Without people who know this process, know it well, do it well, highly organized, efficient, superhero individuals, then this process can just fall apart. I hate that the financial coordinator is so high up on this list, but, and no offense to you, financial coordinator, you're a good person. But if you don't have financial clearance, then the evaluation is very costly, the transplant is costly, and you also have to have approval for medications after transplant. Also adding to this, if we are transplanting people who have active alcohol use, we want to get financial clearance for treatment for intensive outpatient or chemical dependency rehabilitation after transplant. So that's just one more thing. So thank you, financial coordinator. Hepatologist and surgeon, we see the patients together. The surgeons really focus on surgical contraindications. Sometimes people just have an abdomen that is not amenable to removing and putting in a new liver, and it's a case-by-case basis. Hepatologists, we really focus on the medical contraindications. Pharmacists, just key critical in trying to figure out what meds a person needs to be on pre and post-transplant. Social workers, dietitians, these are really key for optimizing people prior to transplant. And then we have additional consultations as needed. Patient selection committee. This occurs for us right now Tuesday mornings. It's an hour long, but it can go as long as we need. We bring to the meeting utility, justice, and respect. And organ stewardship is very, very important. Doing the right thing, as Alan Langness, one of the best transplant surgeons in the country, says. Just always do the right thing and you'll never be wrong. So the decisions: list, defer if somebody is too early, and they continue to follow with hepatology. Defer for completing testing, rehab, or other requirement, or deny. And I feel that deny is, I prefer to say yes before saying no. But sometimes deny, just it happens, and it's sad because people have gone through a very long process to get there, and so those that are deny can come back to hepatology, and it doesn't matter where you are, if you're on the list, not on the list, you're still our patient. So outcomes post-listing. If you can see here, this data is a little bit old, but out to 36 months, you have individuals that are still waiting, individuals that have been transplanted with deceased donor. These are your living donors, a very low rate, and you see those people get transplanted very early. Living donation can be planned, and then removed from their wait list or died. Characteristics of liver transplant recipients. I just want to say a couple things about this from 2008 to 2018. If we look at females and males, more males are transplanted. There are probably many reasons for that, but one of them that's recently been published by my friend and colleague Alina Allen at the Mayo Clinic is that women are disadvantaged by the MELD score. They have lower serum creatinines because they have lower body muscle mass, and so we desperately need to figure out a way to correct the MELD score to compensate for this, to allow for women to be equally competitive for liver transplant to males. We have disparities in race and ethnicity. Some of those are improving. That's encouraging, but we can do better. Metropolitan, non-metropolitan, people in metropolitan areas get transplanted, people in rural do not. And so it's important to have outreach clinics to reach those individuals who may not have access. UNOS regions and OPOs. The regions used to be more important because we would share organs amongst certain states. You will see why that's no longer important. UNOS regions is now important for mobilization and talking amongst ourselves. So we are region 11 here for the United Network for Organ Sharing. OPO is the Organ Procurement Organization. We are region 28, Kentucky Organ Donor Affiliates, right here. Can you imagine living in Texas? Just carry on. So the system prioritizes liver transplant candidates based on geography and illness. So standard donor with a status 1A, those are individuals with acute liver failure. Going down the rankings of MELD score, an organ becomes available and it would first be offered within 150 nautical miles, then 200, then 500, going through these tiers. DCD or older organs are first offered to the sickest and then open to all takers because they are special organs that may not be as pristine as standard donors. You can see now why the regions do not matter, because this is 250 nautical miles and we have 1, 2, 3, 4, 5 regions that could potentially have a particular organ come to them. So Mrs. D, she is a donor biopsy is 5% steatosis. She's blood group O. She's a compatible size to Mr. R, and her donor risk index is favorable. There are a lot of calculators right now floating around, but donor risk index is the one that I like to use. Mr. R, MELD is 31. He's 25 miles away, and he's blood group B, so it is a match. The liver transplant itself, the surgeons have to make 4 anastomosis: caval, hepatic artery, the portal, and biliary. It is a long surgery. It is complicated, and they are truly skilled, brilliant miracle workers with what they do in the OR. I would have been a surgeon. I just don't have that skill set. Typical operation, 4 to 6 hours, operative time 3 to 5, blood transfusion 3 to 5 units. It can be dozens of units in some cases. ICU stay is 1 day, total hospital stay 7 to 9 days, and if people are not local, 1 month outpatient. The most common liver transplant complications are bleeding. People have to return to the OR not an insignificant amount of time. Primary non-function, that's usually from the allograft itself, may have too much fat in it and just can't perform because it's under too much metabolic stress. Thrombosis of the hepatic artery, infection, rejection, bile duct strictures or leaks, and vascular strictures. So back to our case, Mr. R is doing well post-transplant, but he lifted a watermelon at a picnic, and he felt electric pain at his chevron incision. He denies fevers and chills, and labs show a new hyperbilirubinemia and a high alk phos that is brand new over the last few days. So in looking at his belly, his chevron looks really good, so I don't think the watermelon caused a problem. So we reassured him to just stop lifting things that are that heavy this soon after transplant. We did an ultrasound on him. Everything looked normal, but his blood cultures that were drawn by a very savvy intern who had really no reason to do so, but did it anyways, found Enterococcus. Antibiotics were given, bilirubin went down to 2, and we did an ERCP. This is our GI advanced colleagues who do this procedure. And we see here the biliary tree distally looks normal, and then we have here, which is a normal common bile duct, but we have what appears to be a stricture here. Balloon dilation opens that up, and then you have good normal flow. A stent could be placed, and sometimes people have to have stents for a while in order to get that stricture to stay open and resolve. So you manage this with antibiotics, ERCP. Sometimes people need surgical revision, but we usually try to avoid. Other complications, rejection. Knowing that patients are immunosuppressed, they may not mount a response to infection, so have a very low threshold to culture them. So that is the relatively, that is the post-operative complications that can happen soon after transplant. But going out months and years, we have to worry about different sets of issues. And so don't worry about the details of this. This is what we worry about in the clinic. Just thinking about the donor and the type of graft they received and the history of those most immediate or acute complications can drive care for the rest of the patient's life. 6 months post, it's infection, infection, infection. So trying to avoid community or infections that come from the donor or reactivation of infections that exist in the recipient. 1 year post, immunosuppression, working up abnormal liver function, people go back to drinking and people get recurrent NAFLD, and so we need to try to circumvent those things. And then people have a history of hepatocellular carcinoma in their original liver. We have to do surveillance for recurrence of this for at least 2 years out. Special allograft care, as I said, alcohol liver disease. Thomas Starzl said that liver transplant is the ultimate sobering experience, but people go back to drinking. We know that about 25% of the time. Allograft NAFLD, this comes back as well. There's a lot of things we can do to try to ward this off, to improve people's metabolic profile, vitamin E, coffee, probiotics, and sometimes it can be a struggle because people will replace alcohol and the reward with food. And so can't no longer drink, but we can eat. And NAFLD often follows alcohol liver disease in your allografts. Don't worry about this. Just to know that long-term healthcare maintenance is critical for individuals who have been transplanted. The reason why is because the immunosuppression makes people more at risk of certain malignancies and infections long-term. So very similar to every other individual with some tweaks that are aimed at abrogating malignancy risk. So when you're having a bad day, when I'm having a bad day or dealing with medical record system issues, I like to go to Stories of Hope on UNOS and read stories about patients who've been transplanted. They post news stories all the time, and it can really kind of bring meaning to your day, your life, and help to remember why people go into transplant as a career. So back to Thomas Starzl, first liver transplant, 63. It was a young girl who died on the operating table, but he persisted. In the first 7 years that he was doing liver transplants, nobody really survived longer than 23 days. But he continued on. People called him a murderer, but he was a pioneer. So Burden of Genius is a movie about his life. I encourage anybody to watch it. It's very good. So organ salvage, 1,200 people died waiting for a liver transplant in 2019, but 1,300 livers are discarded annually from potential donors. Why is this happening? So we're trying to circumvent donor discards, and so we're now using, we don't really like to call it high-risk donors, but we're using organs that we didn't previously use that may have other things that are affecting them, or the donor might have had some issues. And as long as the recipient knows these things, then many of these organs do just fine. Marginal organs, thinking about ways that we can rehabilitate these. There's this great paper published in 2019 showing that in the time frame that an organ is recovered prior to transplant, you have a window for delivering a treatment to the liver. I'm so glad they published this. However, I wish I would have been there, or I wish I would have been involved, because that is part of my KO8, is working on rapidly defatting the liver using microtubules as my target. And this is my KO8 notice of award. So I'm so excited to do this work. Can't wait to get started. This is our Mayo spheroid reservoir by our artificial liver. Another genius, Scott Nyberg, he has developed this. It is not prime time, and some work on it has been halted due to COVID. The HepAssist circuit is the equivalent of like a dialysis for people with the liver, so with liver problems awaiting transplant. So think of these as maybe the equivalent of a VAD for a liver patient. Both not ready for prime time. So until then, how to be an organ donor. So only 3 out of 1,000 individuals die in a manner that allows for organ donation. There are about 119,000 people on the wait list right now. 22 people die each day waiting for a transplant, and every 10 minutes another person's added to the waiting list. So if you're not an organ donor, I encourage you, donatelifekentucky.org. This is also Donate Life Month, April, so it's really exciting to give this talk at this time, and you can register to be a donor online. I thank you for attending, for listening. I welcome questions here in this forum, and also here's my email address. If there's any questions down the line, door is always open, so please reach out. Thank you so much.
Thank you, Dr. Jophlin. Dr. Kruger, go.
Loretta, that was fantastic. I'm going to ask you later about yellow mustard for leg cramps. I like that you gave some practical approach to, humanism and treating the patient as a real patient, and then also wrapped in a lot of the science. That was really a very, very, very good lecture. I'm sure people have some questions for you, so I'm going to open it up, and either we can look in the chat section, or I don't have.
If anyone wants to ask a question, you can unmute your microphone and ask, or if you would like to post it in the chat area. And if you can give me one moment, actually we actually had a question in the chat area from earlier. If you give me, I got to scroll to find it. Here we go. The question is, how can we justify that those with compensated cirrhosis tend to do better with transplant? Oops, lost it. Let's see. Let me get it back here. Here we go. Okay, again, it is, how can we justify that those with compensated cirrhosis tend to do better with transplant, yet Melded scores tends to favor those that are uncompensated?
I might not have conveyed that correctly. So the outcomes for people with a high MELD and a low MELD, they're not too indifferent. But the higher MELD score, the decompensated individuals, they have a higher risk of dying sooner. And so that's why attempts were made to allocate organs to them faster. I'm not sure that's answering your question. I wish whoever asked that would chime in.
Sorry, I was driving. It's Laura Bishop, and I thank you so much for this talk. I guess the question that I thought was, like, when we're considering allocating, obviously a very scarce resource, and we look at outcome data, it looked like survival really went to people who are well compensated. And obviously you would try to compensate your surgical candidates, but we don't know when the liver will show up. But those with a higher MELD tend to be, at least in my mind from what I've seen, and I'm not a hepatologist, but as a hospitalist, they tend to be more decompensated, which means theoretically based on that survival curve, maybe they have less of a shot of the liver lasting or being really successful with it. And I may be completely wrong and misinterpreting that.
Yeah, it's a very good question, and that was a slide that I actually removed because I was running short on time. There is a hazard ratio that is actually much higher for individuals with lower MELD scores. It's almost sort of a bimodal. You get a sweet spot, and then you can have more risk in people that are sicker, but it's the people with the lower MELD scores that are well compensated that the hazard ratio for transplant is much higher. They have better outcomes without a new liver. And so I can actually forward you that slide showing that SRTR data of the outcomes for high MELDs versus middle MELDs being quite similar.
Thanks so much. That would be wonderful. I'm just trying to consider it in my head and think about the larger world of organ donation, which I don't consider in my daily life. I appreciate it.
So, Loretta, was there another question?
Yeah, actually one more question from the chat, and it's from Dr. Pfeiffer, and he would say, Mark Pfeiffer from Internal Medicine. He says, I know there are associations of coffee benefit with fibrosis/cirrhosis. Are there RCTs? If so, what were the outcome measures?
Did somebody else want to answer that? There have been trials. They've been small. I don't know that data cold. I'll be frank. I think that it's probably more beneficial also in people who have steatosis. So right now, I've just integrated that into my practice since being at Louisville. Because I trust our translational scientists, and I know that some folks have worked on that here. It's not necessarily recommended at other centers yet, but I don't see a reason that it is harmful. And patients are usually happy to hear that they can actually have something, because most of the time it's about what you can't have. So. Yeah, I should probably know that data cold. I apologize.
I know dried neuron, I don't know if there are RCTs, but there's a lot of caffeine and its anti-inflammatory benefits from a scientific standpoint. So it's one of the alternative therapies that we recommend.
Yeah, this is Ashutosh, and I'm not aware of any large RCT looking at caffeine or certainly coffee. And actually, it's not caffeine; it's coffee. The recommendations, and even the European Society for the Study of Liver Disease now recommends coffee as should be encouraged in patients who are at risk for liver cancer, which means basically all cirrhotics. And those recommendations are based on very large cohort-based studies that looked at coffee drinkers versus non-coffee drinkers. And it would be rather difficult to have a randomized control trial with coffee in terms of who will fund it and whether people will be able to get in there to be randomized to no coffee and so on, because it's not considered a medicine, it's a daily food. So we probably won't be getting randomized control trials to address that issue.
I believe the benefit was also seen with decaf, and it has to be standard drip coffee, nothing fancy like espresso. It's just, black coffee.
Absolutely. Yeah, in fact, you're absolutely right. The benefit was indeed seen with decaf. Yeah.
All right. Again, if anyone wants, if you'd like to ask a question, you can unmute your microphone and ask away, or if you'd like to type it in the chat area, we can read it to Dr. Jophlin from there.
I think we should all get a cup of coffee and say thank you, Loretta, for an excellent presentation again, and we look forward to hearing from you some more.
All right. Thank you for the opportunity.
Thank you, Dr. Jophlin. echoing from a layperson standpoint, is very outstanding talk today. So, and just want to let everybody know we will be back next week, same time, same channel, 8 a.m. next Thursday. The presentation will be from pulmonary, and it'll be Dr. Bogdan Moldavino, or as most people know him, Dr. Bobby. So we're looking forward to that. Again, I'll be Dr. Moldavino from pulmonary next week, again, 8 o'clock next Thursday, and we're so happy to have so many folks join us today, and we hope to see you back again next week and the weeks following through the end of the semester here. So thanks again, everybody, and we'll see you next week.
Bye.
All right, take care, Dr. Kruger. Oh, and Tim, I remember to download that thing.
Okay.